Thank you very much for your introduction, and really I would love to congratulate SSBMT for the 10th anniversary, and as well as switching gears. My talk will be about sickle cell transplants and our local National Guard Riyadh experience, including the haploidentical transplantation. It will be switch gears from GVHD to sickle cell transplant and some pediatric data, but also we'll go through the adult data, some of the adult data that Dr. Mohsen Zahrani and Dr. Badr and the team in the adult that shared with us. It is also a continuation in the same theme that the field of stem cell transplantation continues to evolve very quickly. Disclosures about the relation to the talk is some research support for Hopkins 2 trial for voxelotor and from Verstix as well. So we'll go through some introduction, and then we'll go through the pediatric classical approach of match-related donor transplantation, the conventional myeloablative regimens, and then we'll go through the reduced intensity and finish with alternative donor transplantation. So as you know, sickle cell disease is the most common inherited blood disorder in the country that affect at least between 60 to 90,000 patients, even more than that in the recent MOH data. And if you just do the calculation, there are multiple studies and estimation, around 20% at least of sicklers are candidate for, they are severe enough for leaning toward curative therapy such as transplantation or gene therapy. And if you see globally, the interest in transplant and sickle cell and treatment in general have increased dramatically. I mean, the first transplant in 1984 for a sickler with AML, and now you see how the numbers are increasing in different countries around the world. But we have to put one thing in a classical treatment for the selection of those patients. It is very well established, at least in the last 20 to 30 years, that the younger they are, if you use the classical conventional myeloablative therapy, the better the outcome. And studies range from the age of 13 to age of 15, where if you transplant them earlier than that, you will have a better outcome. And the usual outcome that the registries have published, whether in the EBMT or the CIBMT, are talking about more than 95% or more than 94% of them are survivals for more than 1,000 patients. But that's not true for the other kind of alternative transplantation. If you go and looking at those curves in this earlier study, of course, at that time, match-unrelated donor and haploidentical transplantation had a lower, and you could see that the gap of around 30% lower is significant, whether in overall survival or event-free survival. And that put in a stress on who to transplant. And you have two schools in that, and a school that says transplant them early before they get more end organ damage, and everyone with matched sibling donor go and transplant them. But the other, if you look at the number and the population and many other different sources and regulatory areas, priorities go to severe disease. And this is one of the NIH approach had published that long time ago with the some of the indications, as well as the American Society of Hematology guidelines in 2021. But you could see the long list of matched sibling donor, you could go there, but you start to go for alternative and unrelated donor once you have very severe disease, talking about recurrent acute syndrome, requiring ICU admissions, and moya disease, and recurrent or having stroke, putting those patients on regular transfusions program. I took this from Dr. Mohsen, this slide, courtesy go to him, but of course to the publication of Prof. Gluckman. about why the outcome in pediatric and adults, and of course organ damage, multiple transfusions, iron overload, and impaired immunity and are risk factors. So if the overall survival with the myeloablative classically is 95 in pediatrics, in adults it used to be around 81%, maybe higher right now, as we'll come to. So when we dissect that to condition and regimen in a pediatric age group, the EBMT has published also in the British Journal what is the common and BMT Pediatric Working Party. People have changed from BUSI ATG toward other regimens, and in the last publication you would see like 60% of their population are using in the registry trisulfan, fludarabine, thiotepa. Now trisulfan is not approved in all the countries, but this is one of the things that people have been using. In addition to the use of serotherapy. Now in our hospital, with a homogeneous society with a high rate of finding match-related donor, since 2010, a group of multiple generations have done a lot of work in sickle cell, acknowledging previous Prof. Abdurrahman al-Sultan and the whole group in the society. Around 450 patients were allogeneic transplant, but you'll see hemoglobinopathy accounts around 42% or so, and 30% are sickle cell. And the initial 40 patients, when a trial was led by Dr. Prof. Abdurrahman about using REC, did not show at that time in pediatric, similar to what we were hearing from the adult, that the outcome is so great in sickle cell. We've used regimens that was under clinical trial with ATG, melphalan, and fludarabine, and also some other patients were using Campath flu and melphalan. And as you see here, the event-free survival were much lower in the RIC group, and a lot of them had graft failure. They're all survivals, but they all had graft failure. So if you look at the cake in our hospital or how much was done, the majority are myeloablative with TBF regimen, so thiotepa, busulfan, fludarabine, and we have presented that in the last EBMT using this regimen, using thiotepa and targeted busulfan dosing with calcineurin inhibitor and methotrexate as GVHD prophylaxis. And the main indication were recurrent painful crisis in 32%, and 29% of those had a stroke. You also could see here out of those, interestingly, the ages from 2 to 14, but from out of those, 80% had matched sibling, but some of them, like 20%, were match related. It means one of the parents or the cousins, which we not often, we could see it in our population sometimes in IRIX. The busulfan level was ranging accumulative around between 50, around 60 to 70 in general, and as expected, the neutrophil engraftment and platelet were between the median 20 and 29, with acceptable full donor chimerism and a mixed donor with no graft failure. And the main complications were around mild VOD in 15%, and occasional press, although they have managed as many other patients with sickle cell with Keppra prophylaxis and keeping the platelets high and blood pressure control. We also found here as well that they have some infections, but the overall survival of those, similar to international, it's around 99%, but we had one mortality at day 88 from IPS or idiopathic pneumonia syndrome, but we did not have graft failure. But we have also some elements of GVHD. If you combining, they're around 6%, some of them had both acute and chronic, but they're all mild and none had severe. On the other end, our colleagues in the adult have published initially collaboration with the NIH group, and later on our own data here, starting from 100 patients to almost now 300 patients, using the alemtuzumab TBI regimen with sirolimus as an immunosuppressor. But before that, those patients get hydroxyurea 3 to 40 milligram per kg, and for at least 60 days with hypertransfusion, and that made an excellent outcome. And as you see here on the side, compared to the outcome published by earlier in 2017, it's with a good follow-up, it's in a higher range as an overall survival around 90 plus percent. So then came the question here, who to do and what is the advantage of each? And maybe in pediatric it's a little bit different than the adults based on their immune system. The alternative donor in terms of MUD, haploidentical or cord has been raised. Now I'll not spend time about cord blood transplantation, but it's still one of the, if you have a family matched cord blood in a high-risk patient, you could consider it in a sickle cell patient. We've done that only in one patient and it did well, but this is something hopefully in the future with cord blood expansion. But the problem with match unrelated donor in the sickle cell, that it has a high rate of GVHD, more than 30% if you see in this publication by Shinawi et al. And we elected in our society just to do only some match unrelated donor, but only limited to local registries, knowing the consanguinity and the relationship and we just added, as Prof. Marty, the classic ATG prior to infusion for 3 doses, and those patients did well. Now, moving to haplotransplant, it's a long story, but the Hopkins group looking at the PTCY, because this is the most popular, accessible way in our country and multiple countries around the world, and it's cheaper. They started initially with an approach using the flu cyclo ATG and a TBI of 200 only, but that led to a lot of rejections, and about 40% of those patients rejected. Later on, multiple consortium around the world have been focused on what to do and modify this regimen. So a group have increased and modified the TBI to 400, and they decreased the rate of graft rejection down lower to around 10%. On the other hand, the group in London added thiotype around 10 milligram earlier per kg and modified in the preconditioning with time, in addition to changing in the GVHD prophylaxis area. And it was also promising that led later on to a collaborative group between multiple countries, North America, Europe, as well as the Vanderbilt group with Dr. Aditola Kasim and the group, and the St. Mary groups, and in Saudi Arabia between the National Guard and King Faisal Hospital and the adult group. The pediatric have also got involved in that lately, and we're using this regimen, adding thiotepa, but on top of that, doing hydroxyurea very rigidly for 60 days and hypertransfusion to keep the hemoglobin high and keep the hemoglobin S less than 30%. So the reason I'm saying this, because the publication recently, it was very interesting by Aditola and the group in that consortium. And you look here that the outcome and the overall survival is excellent, around 5% mortality with this haploidentical approach, and around 10 or 11% had graft rejection. But when you dissect that for those 70 patients into who are the patients who rejected, they end up to be, all of them are pediatric patients, less than 18. So if you look at the slide on the left, the pediatric cohort, and you do the sub-analysis, around 70% the event-free survival. So it means 30% they rejected. Now they all had autologous recovery. On the other hand, in the adult group, they were like the rate of mortality was around like 5-7% because of infectious complications. What's this other striking thing? The GVHD rate was 10%. So another subgroup. So after this publication and looking at the data, we tried to segregate, and we had the pediatric group in the National Guard group, and St. Mary in London and the Vanderbilt group have collected the data looking at the hydroxyurea and hypertransfusion for those indications for haplotransplant like stroke and severe cerebrovascular and severe vaso-occlusive crisis. We had 26 patients, and the age ranged from 2 to 16 years with a median infused TNC of 4 and the median QCD34 of 4.7. Remember, those are all bone marrow, they're not peripheral blood. The median neutrophil engraft were around 21 days and a platelet of 41 days, and the outcome was better than expected compared to the whole group. So a good full donor chimerism in a majority of patients, and this is what we got. Overall survivor 94% and a disease-free survivor around 89%. Now there was one death late because of pneumococcal sepsis, was done in otherwise off immunosuppression patient who was non-compliant, and there was no cases of VOD. But the other problematic part was the GVHD. So if you calculate grade 3 and above, allow for acute around 11%, and if you look at moderate to severe, around 4 patients, so around 15%. So this is still could be something that we could improve in. The strategies, as you know, for haplotransplant in Europe is also different. You could also do the ex vivo depletion with alpha beta depletion. And the publication, at least in the pediatric age group, of 20 patients with haplo who received myeloablative TFT, so a treosulfan based, is also promising with 90% overall survival, but also still a GVHD around 20%. So based on that, the conclusions, we are seeing that the choices of preparative regimen and conditioning regimen is still evolving and getting better. The use of alternative donor BMT is still something that also evolving, especially the haploidentical setting. For the match unrelated with the newer GVHD prophylaxis, I was speaking to my mentor, Dr. Abdullah, and we were talking about other agents like abatacept and others, and how to incorporate that in the match unrelated and mismatch unrelated donors. And of course, gene therapy is one of the things that also would be on the table to discuss. So with that, I would like to thank you for listening, and sorry if I exceeded time a little bit. Of course, thanks to all the patients who contributed to this. Of course, the huge team between the medical, the clinical, the laboratory, stem cell lab, and the apheresis teams, and the support from everybody. And again, thank you for SSBMT.